Hey everyone, welcome back, PG students, to Anesthesia Learners Academy. Today, we're diving into a super high-yield explainer on mastering pheochromocytoma management, specifically tailored for your fellowship exams. If you're looking for the absolute most direct, structured way to lock down this incredibly complex topic, you are in the exact right place. Let's get right into it.
So think about this for a second. We're going to kick things off with a classic board-style framing question, just to highlight the absolute physiological chaos this tumor can unleash. What is the ultimate test of an anesthesiologist's hemodynamic control? Well, it's a situation that forces you to anticipate, rather than just react to, some truly profound extremes. And that situation, managing a patient with a pheochromocytoma.
Okay, here's our roadmap for today's explainer, mirroring the chronological clinical journey, which, by the way, is exactly how you'll be tested on it. We're going to hit the core challenge, preoperative optimization, intraoperative management, how to handle those terrifying hemodynamic crises, post-op ICU care, and finally, your high-yield exam takeaways. All right, Section 1, the Pheochromocytoma Challenge. Let's set the stage with the fundamental problem these tumors present to us as anesthesia providers. So, as we know, a pheochromocytoma is a catecholamine-secreting tumor of the adrenal medulla. It classically presents with that famous triad, paroxysmal headaches, sweating, and palpitations. But for us in the OR, it's critical to understand that an undiagnosed or poorly managed pheo can precipitate a totally fatal perioperative hypertensive crisis. You are literally dealing with a tumor that acts as a massive reservoir of epinephrine and norepinephrine, just waiting to be squeezed. Moving right along to Section 2, preoperative optimization and goals. This is the setup, where meticulous preoperative prep over 1 to 3 weeks is our absolute first line of defense. You simply cannot rush these patients into the operating room. Now, you absolutely have to know the Roizen criteria for your exams. It's the gold standard checklist to confirm a patient is actually optimized for surgery. We need to see blood pressure strictly less than 160/90 for the 24 hours prior. We need no orthostatic hypotension dropping below 80/50. There should be 0 ST or T wave changes for an entire week, and less than 5 PVCs per minute. Hitting all these marks proves your medical therapy is actually doing its job. So how do we actually get our patients to meet those strict criteria? For the boards, remember this cardinal rule. Alpha blockade, like phenoxybenzamine, and aggressive intravascular volume expansion must always precede beta blockade. Why? Because if you block beta-2-mediated vasodilation first, you leave all that alpha-1-mediated vasoconstriction completely unopposed. And that precipitates acute heart failure. Alpha, always before beta, no exceptions. But what if standard blockers aren't cutting it? That's where our adjuncts come in. Alpha-methylparatyrosine, or mediirosine, is an incredibly useful tool that actually decreases catecholamine production by a whopping 50 to 80% by inhibiting tyrosine hydroxylase. Keep in mind that specific adjuncts like mediirosine or highly titratable calcium channel blockers like nicardipine offer vital alternative pathways to stabilize your patient. Okay, let's wheel the patient into the OR. Section 3, intraoperative anesthetic management. The climax of this journey really begins with your careful selection of induction and maintenance agents. Now, this is classic board question material. The crucial point here is knowing exactly what not to push. You have to contrast the histamine-releasing or sympathomimetic drugs that you must avoid against the safe, stable alternatives. You absolutely want to avoid morphine, atracarium, ketamine, and ephedrine because these can trigger massive catecholamine release. Instead, rely on the safe alternatives, propofol, fentanyl, vecuronium, and sevoflurane. Keep that sympathetic nervous system as quiet as humanly possible. All right, now for the main event, Section 4, hemodynamic crises and control. Here is where we face the dual intraoperative threats of this surgery. Extreme hypertension, followed rapidly by sudden, profound hypotension. First up, intraoperative hypertension. We're talking severe, terrifying spikes in blood pressure occurring directly from a massive catecholamine release. And the trigger? Physical manipulation of the tumor by the surgeon. You have got to anticipate profound hypertension the very moment the surgeon starts manipulating that adrenal gland, or even just insufflating the abdomen for laparoscopy. You have to be ready before they even touch it. To combat those spikes, you must have your rapid response arsenal memorized. You'll be heavily relying on potent, super fast-acting vasodilators like sodium nitroprusside, or a highly titratable calcium channel blocker like nicardipine. Phentylamine is fantastic for direct control of the catecholamine surge. And remember,
You only treat the tachycardia with a beta blocker like esmolol after you've managed the blood pressure. But then, the exact moment the adrenal vein is clipped, boom, you immediately face post-ligaturine hypotension. This is a sudden, profound drop in blood pressure immediately following that vein ligation. Because of the abrupt withdrawal of catecholamines combined with your patient's residual alpha blockade, you have to instantly switch gears. You're now managing rapid onset, profound shock. Managing this means you have to be highly proactive. You actually want to shut off all your vasodilators immediately prior to clipping. You need aggressive volume expansion, meaning you are pushing crystalloids well before that vein is ever ligated. And you'll treat this sudden catecholamine unresponsive state with potent pressors like vasopressin, simply because their alpha receptors might be completely downregulated at this point.
Phew, okay, the surgery's done. Let's move to Section 5, post-operative ICU care. We're out of the OR, but our patient remains in a highly precarious metabolic state. The tumor is out, the patient is closed. So are we finally safe? I pose this because examiners love to test this concept. The answer is absolutely not. That metabolic and hemodynamic roller coaster, it continues deep into the post-operative period. Let's look at the immediate threats in the ICU. These are great test questions because they're a bit counterintuitive. You've got persistent hypotension from residual phenoxybenzamine, which requires ongoing aggressive volume management. Then there's sudden resistant hypoglycemia. This happens due to hyperinsulinemia once that suppressive tumor is gone, and that mandates strict, continuous glucose monitoring. You might also see somnolence just from the sudden withdrawal of all those activating catecholamines. All right, let's bring it all home. Section 6, high-yield exam takeaways. Let's look at how all of this builds into the ultimate high-yield summary for your upcoming fellowship exams. Here they are, the 5 golden rules of Pheo management. Really commit these to memory. 1. Alpha always precedes beta blockade. 2. Confirm your optimization with the Roizen criteria. 3. Avoid histamine-releasing and sympathomimetic drugs like the plague. 4. Anticipate hypotension with manipulation and hypotension with ligation. And 5, monitor aggressively for post-operative hypoglycemia. These 5 points represent the absolute highest yield testable concepts across the whole perioperative journey. Keep this core philosophy in mind, right? The management of pheochromocytoma is the ultimate test of an anesthesiologist's ability to anticipate rather than react to profound physiological extremes. Proactive anticipation is exactly what separates a good resident from a great fellowship-level anesthesiologist. You have got to be 2 steps ahead of the surgeon and the tumor at all times. And that wraps up our review. If this explainer helped to clarify your exam prep, please hit that like button, subscribe to the Anesthesia Learners Academy platform, and share this with your fellow PG students. Before you go, I want you to ask yourself, if you encountered a Pheo patient in the OR tomorrow, would you merely react to their vitals, or are you prepared to command their hemodynamics? Keep studying hard, always anticipate the extremes, and I will see you in the next explainer.